You know that feeling. Maybe your body's changing in ways you just don't recognize. Could be new aches, pains, maybe this fogginess in your brain that wasn't there, even heart palpitations perhaps.
Yeah.
And you take these worries to your doctor, right, hoping for some insight, some relief. But sometimes the response, well, it just isn't what you need. You might hear, oh, that's just, normal aging, or maybe trying to manage your stress better. Yeah. Or, and this is something the source we're looking at today really highlights, maybe you get told that new joint pain or suddenly high cholesterol, even though you live healthy, is just, I don't know, unlucky. Or that you just need to continue working on a diet that's already pretty good. That feeling of being dismissed, like maybe it is all in your head, or part of getting older you have to accept. It's really disheartening, isn't it?
It is. And unfortunately, that experience, that feeling of dismissal, it's not just common. It's actually a narrative that our source for this deep dive excerpts from The New Menopause by Dr. Mary Claire Haver explicitly connects to, well, a long history of how medicine has approached women's health.
Exactly. So that's what we're doing today. We're taking this really insightful source material and we're going to really get into it. Our mission, basically, is to unpack what's genuinely happening during this major life transition, often called menopause. We want to understand the biology behind it, why it's been historically, misunderstood and often undertreated. We need to talk about the actual range of symptoms you might experience, way beyond what most people think. And the potential health risks, too. And maybe most importantly, what strategies are actually out there for managing it. Things like hormone therapy, but also fundamental lifestyle changes.
Yeah, this deep dive is really for you, our listener. Whether you're going through this right now, or maybe you see it on the horizon, or perhaps you're supporting someone who is navigating it, the whole goal here is to arm you with knowledge straight from this source to give you a clearer picture and, crucially, to empower you to, advocate for yourself more effectively.
Absolutely. We're here kind of like guides through the material. I'll bring the questions, maybe point out the relatable stuff, the surprising bits.
And I'll provide some of the deeper context and insights, drawing directly from what Dr. Haver writes in these excerpts.
Oh, good.
But first, a really crucial point. One, the source itself makes very clear right at the beginning. The information we're discussing today, it's purely for educational purposes. It absolutely cannot and shouldn't replace professional medical advice. Always consult your own doctor for any health concerns or before making any decisions about your treatment or care.
Yes, that's so vital. Please keep that in mind. Okay, let's really get into this then.
Right. Let's start exactly where you began that frustrating feeling of dismissal. The source material tackles this right away. It frames it not just as bad luck, but as a systemic issue, something rooted in medicine's past. It points to this history where, medical professionals sometimes attributed women's physical symptoms to psychological factors, like being overly sensitive or maybe just unhappy. The author even mentions that damaging historical phrase, "It's all in her head."
Wow. So it's not just in my head that I felt dismissed. It's a pattern the source actually calls out in the system itself.
Precisely. But then the source offers this really profound counter-truth to that dismissal. It's a core revelation, something it comes back to again and again. Those symptoms you might be feeling, whether it's the familiar ones like hot flashes or the less obvious ones like, say, joint pain or brain fog, according to this source, they are the direct biological consequence of declining estrogen levels.
Okay, this feels like a really important point to reiterate. It's not just some vague getting older thing happening. It's a specific hormonal change causing wide-ranging effects.
That is exactly the message. And while menopause itself, the end of periods, is a natural biological process, your ovaries are, in fact, winding down reproductively. The source is very clear on this. Natural does not mean its effects are benign. It doesn't mean those effects shouldn't be addressed or treated. That's a key insight right there. Natural doesn't equal harmless, and the consequences deserve real medical attention.
That distinction changes everything, doesn't it? And the source really dives deep into why this drop in estrogen is such a big deal, going way beyond just reproduction.
It certainly does. This is where it gets fascinating. The source reveals the incredible, widespread impact of estrogen. It explains that estrogen has receptors. Think of them like little docking stations in cells throughout almost every single organ system in your body. We're not just talking ovaries, we're talking your heart, your brain, your bones, how you regulate blood sugar, your skin, your muscles, lungs, even your immune system, your gut, your eyes, ears, mouth, joints. The list goes on. So, as estrogen levels drop during the menopause transition, the source explains that the cells in all these different systems lose that crucial hormonal support they've relied on, often for decades.
So the symptoms aren't just random issues popping up. They're a direct result of estrogen basically leaving the building and all these different body systems that depended on it.
That's precisely the biological reality the source lays out. And this reality, it manifests in an astonishingly wide range of potential symptoms. The source actually lists dozens. It's far, far beyond just the hot flashes and night sweats everyone knows about. It's really quite eye-opening.
Yeah, I was genuinely surprised by some of the symptoms mentioned, things you'd probably never, ever connect to menopause on your own.
Oh, absolutely. The source points to less commonly recognized things like frozen shoulder, or maybe a chronic cough that just won't clear up, tinnitus, that ringing in the ears, benign position, vertigo, so dizziness, even things like kidney stones.
Kidney stones, really.
Yep. Itchy ears or skin, a burning sensation in the mouth or on the tongue, TMJ or jaw issues. And then, yes, the ones that are maybe more recognized but still often dismissed, like memory issues, that brain fog people talk about, joint pain, hair thinning or loss, even new adult onset acne, IBS-like symptoms, and those scary heart palpitations.
Okay, hold on. Kidney stones,
Sir?
burning mouth, tinnitus. If you had those, you'd likely see a urologist or a dentist or an ear specialist, right?
Yeah.
Not necessarily someone focused on menopause.
And that is exactly the challenge the source highlights. Because these symptoms are so varied and they often mimic other conditions or they just get brushed off as, oh, you're just getting older, women are frequently sent on these fragmented health journeys, seeing multiple specialists, doing tons of tests, maybe trying different treatments, without ever connecting it all back to the underlying hormonal driver, the drop in estrogen. The source uses this phrase that women have to scramble to be believed because their whole complex set of symptoms just doesn't fit neatly into one diagnostic box.
Right. But the source tries to help draw those lines, connect the dots back to the biology. It shows why these specific, sometimes seemingly unrelated symptoms can happen.
It does. It gives examples like joint pain and muscle aches. It connects that directly to estrogen's vital role in maintaining muscle and bone health, memory issues, brain fog. The source links us to the fact that there are tons of estrogen receptors in the brain. It suggests estrogen decline might even contribute to neuroinflammation,
Okay.
heart palpitations. Those can be tied to diminishing estrogen levels, messing with the autonomic nervous system, which helps control your heart rate. Skin changes, getting thinner, drier, losing that plumpness from collagen loss, that process accelerates after menopause. The source notes a significant chunk of collagen can be lost just in the first 5 years post-menopause, directly linked to estrogen decline.
Wow, 5 years. That's fast.
It is. And then there's GSM, genitourinary syndrome of menopause. That covers things like vaginal and vulvar dryness, pain with sex, maybe more UTIs. The source describes this as a direct consequence of estrogen deprivation affecting those sensitive tissues in the bladder, urethra, clitoris, vulva, and vagina.
So the source really provides that crucial why behind this huge, often confusing list of symptoms.
Yes, it does. And it constantly reiterates this point. This isn't just about feeling uncomfortable today. The stakes, according to the source, are actually much higher in the long run. It explicitly links the decline in estrogen to increased risk factors for some of the leading causes of death and disability in women. We're talking heart disease, stroke, Alzheimer's disease, type 2 diabetes, and serious conditions like osteoporosis, bone loss. The source is really unambiguous here. It says losing the protective effects that estrogen provided for decades is a very big deal and should be treated as such. This point that addressing menopause isn't just about hot flashes now. It's about your long-term health, your longevity. That's a vital takeaway the source really wants you to grasp. It's a point we need to keep coming back to.
That definitely shifts the perspective. It reframes menopause from just, I don't know, an inconvenient life stage to a really critical moment for your future health.
Absolutely. And understanding that biological reality, the sheer breadth of estrogen's impact, makes the next theme the source explores even more, frustrating, which is, why does the medical system often fall short in recognizing and treating this major transition effectively? Let's circle back to that feeling of dismissal you started with.
Right. If it's such a huge biological event, why is it often so hard to get the right kind of care? The source really digs into these systemic reasons for this, doesn't it?
It does. The number one issue, according to the source, is a widespread lack of up-to-date awareness and, frankly, sufficient education about menopause and its effects right within the medical community itself. The source uses this really good analogy. It says doctors are trained to identify specific symptom clusters that match a clear diagnosis, like recognizing a certain type of bird by its distinct features, right?
Hmm.
A robin looks like a robin. But menopause, with its incredibly wide-ranging symptoms that can fluctuate, that are unique to each woman, it doesn't present like a neat, easily identifiable duck or robin.
Ah, okay. So it doesn't fit the standard match the symptoms to the disease model very well.
Exactly. And the source is pretty blunt about the training gap. It says, and I'm paraphrasing here, not many doctors have been taught how to practice medicine when it comes to the matter of menopause. The author herself, Dr. Haver, even though she's an OBGYN, openly admits that she was an uninformed menopause provider for years because her standard medical training simply didn't cover it adequately.
Wow. That's a really powerful admission from an OBGYN. It really speaks volumes about how big this educational gap must be.
It really does. The source goes into some detail about the historical lack of formal training. Often, maybe just 1 hour in the entire medical school curriculum. Perhaps 6 hours total throughout residency. Historically, there just haven't been dedicated menopause clinics where doctors could get specialized training, unlike, say, cardiology or endocrinology clinics for other complex conditions. And here's a critical point the source makes. Menopause education is still not prioritized in the requirements for board recertification in many specialties. That includes OBGYN.
Wait, not even for OBGYNs. That seems unbelievable.
It's a major factor contributing to the problem, according to the source. While thousands of medical articles get published every year, very few related specifically to menopause are included in the required reading lists or the question banks for board recertification exams. There often isn't even a dedicated menopause category in standard board review materials, unlike areas like surgery or ethics or oncology.
So basically, a doctor who really wants to stay current on menopause care has to actively seek out, read, and interpret all this updated research entirely on their own time, on top of what's already a crazy busy schedule.
Precisely. The system doesn't automatically build in this essential ongoing education. And this ties into another systemic issue the source identifies, an insufficient definition of aging within medicine itself.
How does that play into it?
Well, the source argues that medicine tends to define aging mostly by chronological age, just the number of years you've been alive. But it proposes we also need to consider what it calls endocrinological age. It points out that our ovaries age significantly faster than most other organ systems, roughly twice as fast. So this narrow focus just on the calendar years means that the rapid and profound hormonal decline during menopause and all its systemic effects often isn't seen by the medical establishment as a primary treatable endocrine deficiency. Instead, the consequences just get filed under normal aging stuff that happens when you hit 50 or 55, rather than being seen as an endocrine issue tied specifically to ovarian aging that could potentially be addressed with interventions like hormone therapy.
Okay, so the standard medical view of aging kind of misses this really important rapid hormonal shift that's happening.
Yes, it overlooks the endocrinological driver behind many of the changes women experience in midlife. The source also briefly touches on broader systemic issues, things like bureaucratic mismanagement of funds and systemic deficiencies in the money allocated specifically for menopause research, for developing medical tech, for products and treatments. And this lack of funding and focus directly impacts innovation and ultimately your access to quality care.
All these barriers, the lack of training, the view of aging, the funding issues, they all add up to create that frustrating patient experience we started with.
Absolutely. The source describes the end result as these long and costly wild goose chases for patients. Women getting sent for multiple tests, seeing various specialists, maybe a cardiologist for palpitations, a rheumatologist for joint pain, getting cholesterol checks, thyroid tests, trying to diagnose symptoms that actually stem from the fundamental hormonal shift of menopause, but are being looked at totally in isolation. And this costs you, the patient, so much time, so much money, and frankly, a huge emotional toll from feeling unwell and just not being heard.
It paints a really clear picture of why the system often struggles to provide the right care. But the source does offer a little bit of hope, suggests things might be changing.
It does offer some signs of hope, yeah. The source identifies what it calls a growing groundswell of change. This is partly driven by, collective patient frustration and people speaking up, advocating for themselves. We're also seeing increasing corporate investment in menopause-focused products and services, the femtech space. And importantly, medical societies are starting to shift their focus. The source specifically mentions the American Heart Association now formally recognizing the link between the menopause transition and increased cardiovascular risk. They've even published scientific statements to guide doctors on this.
Okay, so the science is definitely moving forward, and hopefully slowly the medical system and just general awareness are starting to catch up.
Yes, the source frames it as needing long-haul commitment. It's not just a passing trend, but the momentum is definitely building. So now that we've kind of laid out the biological reality and the systemic challenges, let's move on to providing that roadmap the source suggests is so important for now, understanding the actual stages and the timing of menopause itself.
A roadmap is definitely needed. It seems like the whole process isn't always, straightforward or obvious when you're in it.
It's often not. The source provides some clear definitions for the stages. First up, there's perimenopause. This is basically the extended transition period leading up to your final menstrual period. The source notes that you often only recognize it in hindsight, looking back and thinking, oh yeah, that's when my cycle started getting weird.
It's characterized by hormone levels, primarily estrogen and progesterone, starting to fluctuate, sometimes quite wildly.
Okay, so perimenopause is that phase of hormonal ups and downs and changing cycles before the periods stop for good. Exactly. Then there's menopause itself. And this is a really critical point the source emphasizes again and again. Menopause is technically one specific moment in time. It's defined retrospectively. It's the point when you've gone 12 consecutive months without having a menstrual period.
Right. Not a phase you're in, but a single point marking that full year without a period. That's a key distinction.
It is. The source gives the average age for this event as 51 in the U.S., but the normal range is typically between 45 and 55. If menopause occurs before age 45, it's considered early menopause. And before age 40, it's defined as premature menopause.
Okay. And then postmenopause is just everything after that 1 year no period mark.
Correct. That's the rest of your life after hitting that official menopause date. The source then goes a bit deeper into the biology behind this ovarian decline. It links chronological aging directly to reproductive aging. Basically, over time, the number of follicles in your ovaries naturally decreases. These follicles are where the eggs are stored, but they also contain the cells that produce most of your estrogen, progesterone, and some testosterone.
Got it. So fewer follicles mean the hormone factory is slowing down production and eventually, closes shop.
Pretty much. Your hypothalamus, which is a part of your brain, it senses these falling estrogen levels. It responds by releasing more of a hormone called GnRH. GnRH then signals your pituitary gland, another brain area, to pump out more FSH, follicle-stimulating hormone, and LH, luteinizing hormone. These FSH and LH hormones are supposed to tell the ovarian follicles, hey, make more estrogen.
Okay, so the brain is essentially yelling louder and louder at the ovaries, trying to get them to produce hormones.
That's where the source uses a great analogy. It says your FSH and LH levels get really high during this time because the brain is persistently sending these strong signals. But the ovaries, having fewer follicles left and those remaining follicles being less responsive, they just can't really pick up the call or respond effectively anymore. It's like the source says calling someone hoping they pick up, but the signal isn't getting through because the receiving end is depleted. Your body is trying hard to make hormones, but the capacity just isn't there anymore. And it's this fluctuating and eventually declining hormone production that leads to the irregular cycles and all those withdrawal symptoms we talked about, characteristic of perimenopause and then leading into menopause.
That analogy really makes the biology clear. And the source stresses that the timing of all this, like even the age you naturally reach menopause, has a real long-term implications for health.
It does, and this is another one of those points this source really wants to reiterate. Menopause isn't just about periods stopping. It signals and actually initiates a phase of accelerated cellular aging throughout your body. The source cites research showing that reaching natural menopause at a later age is generally associated with better long-term health outcomes. Things like a longer life expectancy, higher bone mineral density later in life, lower risk of fractures, and even reduced risk of heart disease.
And that's directly because you've had the protective benefits of estrogen for a longer period of time.
Exactly. Estrogen provides these protective effects across so many systems. The longer you benefit from that natural protection, the better it generally is for your long-term health trajectory. This is why, the source argues, it's important to pay attention to early changes in your cycle or symptoms, especially if they seem to be happening earlier than that typical 45-55 age range.
Are there specific things, events, or factors that can actually cause menopause to happen earlier than expected?
Yes. The source outlines several scenarios where your ovaries might start functioning prematurely. The most immediate is surgical removal of both ovaries. That's called a bilateral oophorectomy. That causes immediate surgical menopause, regardless of your age. If you have just one ovary removed unilateral oophorectomy, it doesn't cause immediate menopause, but the source says it can accelerate the onset of your natural menopause by about 1.8 years on average, because you've essentially lost half of your remaining egg supply.
Okay.
And interestingly, even having a hysterectomy removal of the uterus, even if they intentionally leave your ovaries in place, that can still accelerate menopause onset. The source mentions by an average of about 4.4 years, likely due to disruption of blood flow to the ovaries during the surgery.
Wow. So any surgery involving those organs can really shift the timeline significantly.
It definitely can. Other factors include certain chemotherapy drugs and radiation treatments, which can damage ovarian function and lead to premature hormone loss. And then there's a condition called premature ovarian insufficiency, or POI. This is when the ovaries stop functioning normally before the age of 40. The source makes an important point here, calling it insufficiency rather than complete failure, because sometimes in POI, hormone production can still happen intermittently. It's not always a total shutdown. It also highlights the huge emotional and psychological impact that often comes with a POI diagnosis, combining the medical challenges with the often profound grief or distress related to reproductive function ending unexpectedly early.
Right. But
That-
regardless of why it happens early, surgery, treatment, POI, the source really emphasizes that this early loss of hormones comes with accelerated health risks.
It absolutely does. This is another key point to reiterate. The source reinforces that losing ovarian function early speeds up both the onset and the severity of typical menopause symptoms. But crucially, it also significantly increases your risk for those major long-term health problems we keep mentioning: heart disease, osteoporosis, cognitive decline. The source states very clearly that it is critical to have a conversation about menopausal hormone therapy, MHT, in cases of surgical menopause or spontaneous early menopause like POI. The goal isn't just symptom relief, it's specifically to mitigate these significant accelerated health risks. It even provides some compelling examples from research, like studies showing MHT can actually eliminate the increased cardiovascular risk seen in women who have their ovaries removed before menopause, and other studies suggesting improvements in cognitive function when MHT is started within 5 years of menopause onset and used for at least 10 years.
That point feels incredibly important to hammer home for early menopause. Considering MHT isn't just about feeling better day to day, it's presented as a crucial intervention for protecting long-term health.
It absolutely is. So understanding these stages, the timing, the potential impact of early menopause, it all provides essential context for what we need to discuss next. Exploring the available treatment options, particularly menopausal hormone therapy, which the source gives a lot of attention to.
Okay, MHT. This has such a complicated history in the public mind, right? Often surrounded by fear, mostly because of that big study from years ago, the WHI.
It certainly does, and the source tackles this directly by revisiting the legacy of the Women's Health Initiative, or WHI study. It acknowledges the widespread fear, the confusion that followed the initial reports of the WHI findings back in the early 2000s. Many women stopped therapy, many doctors became hesitant to prescribe it, but the source provides some really vital context by explaining the difference between the type of risk that was often reported versus maybe a more helpful way to look at it.
Can you break down that distinction? What does the source say?
Okay, so the source explains that the media headlines and even some initial medical summaries often focus heavily on relative risk. For example, saying something like, women on MHT had a 26% increased risk of breast cancer, or whatever the number was for a specific outcome. While those relative percentages might be statistically accurate, the source argues that looking at the absolute risk gives a much clearer, more realistic picture for an individual woman.
Right, so the absolute risk is more like how many actual extra cases of something occurred in, say, 10,000 women using MHT compared to 10,000 who won't.
Yeah.
Not just the percentage increase from a usually very small baseline number.
Exactly. The source emphasizes that understanding absolute risk is crucial because often, even if the relative risk sounds high, the absolute increase in risk for these often rare events is actually very, very small for most women. It suggests that the intense focus on relative risk in the past really contributed to an exaggerated perception of danger surrounding MHT.
That's such an important nuance, one that definitely got lost in a lot of the public conversation back then.
It really did. And this understanding, this clearer perspective on risk, leads the source to highlight the updated scientific consensus on MHT. It quotes or paraphrases the core message from the major position statement released by the Menopause Society, formerly NARIS, in 2022. This represents the current expert view. And that consensus is, for most healthy women who are under the age of 60 and are within 10 years of starting menopause, the benefits of MHT generally outweigh the risks.
That sounds like a really significant shift from the older, much more cautious recommendations. Many people probably still remember that whole idea of using the lowest possible dose for the shortest possible time, and maybe only if your hot flashes were absolutely unbearable.
It is indeed a major evolution in the medical understanding and the recommendations. The source presents this updated consensus as a much more favorable view of MHT for many, many women, especially when you factor in not just symptom relief, but also those potential long-term health benefits. And the source then goes into quite a bit of detail about what those benefits actually are.
Okay, let's revisit some of those key benefits the source emphasizes again. What does MHT help with?
Well, for symptom relief, it's consistently highlighted as being very, very effective, particularly for those really disruptive vasomotor symptoms, the hot flashes and night sweats. The source includes some powerful anecdotes from patients, like one woman describing feeling her quality of life improved by 1,000%, literally within a week of starting MHT. Her hot flashes gone, night sweats stopped, heart palpitations eased, joint pain significantly better, just dramatic relief.
Wow, 1,000%. That's
Yeah.
quite an endorsement.
It illustrates the potential impact, right? Beyond hot flashes, the source notes strong evidence for MHT's effectiveness for GSM, those genitourinary symptoms like dryness and painful sex. Also for joint pain, sleep disturbances, and mood changes. It specifically mentions MHT helping prevent new onset depression during the perimenopause transition. It also touches on promising or still developing evidence for benefits in other areas, like maybe helping with dry eye, burning mouth syndrome, tinnitus, that dizziness called BPPV, and potentially even slowing the progression of TMJ or jaw problems, though it's careful to distinguish where the evidence is really solid versus where it's still emerging or maybe conflicting.
Okay, so the immediate relief from symptoms can be pretty dramatic and cover a surprisingly wide range of issues. What about those crucial long-term health risks we keep talking about? How does MHT fit in there, according to the source?
This is where the source really connects MHT back to protecting future health. It reiterates that statement from the American Heart Association, acknowledging the increased cardiovascular disease, CVD risk, that comes with the menopause transition. And it brings back that important concept we touched on, the timing hypothesis.
Right, remind us about the timing hypothesis again in the context of MHT.
Okay, so the source explains that the protective cardiovascular benefits of MHT seem to be most pronounced when therapy is initiated earlier in the menopause transition. Generally, within those first 10 years after the final period, and ideally closer to the onset. The theory behind this is that MHT started in this window of opportunity might be more effective at preventing the development of coronary artery disease, hardening of the arteries. It might help keep blood vessels healthier. Whereas starting MHT much later, say 10 or 20 years past menopause, when significant plaque might have already built up, might not offer the same preventative benefit, and in some older studies, there was even a suggestion it could potentially increase risk slightly if started very late, perhaps by destabilizing existing plaque. The source points to a specific finding from a subset analysis of the WHI study itself, showing a significant reduction, like a 40% lower risk of heart attack in women aged 50 to 59 who used estrogen therapy compared to placebo. This supports the idea of benefit when started earlier.
Okay, so that window of opportunity, starting closer to menopause onset, seems really critical for maximizing those potential heart health benefits. That's a key takeaway.
It's a very key message the source emphasizes. Beyond heart health, the source reiterates MHT's significant benefit for bone health. It clearly states that MHT reduces the risk of fractures related to osteoporosis, even in women who might already have low bone density or other risk factors. It's a primary prevention strategy for fractures.
Makes sense, given estrogen's role in bone maintenance.
Exactly. For cognitive health, it repeats that finding from research suggesting potential benefits, particularly for things like verbal memory, when MHT is started within those first 5 years of menopause and used for at least 10 years. It also touches on potential metabolic benefits. It notes that MHT may offer some protection against developing insulin resistance and non-alcoholic fatty liver disease, NFLD. It specifically suggests that transdermal estrogen patches or gels might be particularly helpful for NFLD risk. But it does qualify this, saying more research is really needed before MHT is broadly recommended just for preventing these specific metabolic conditions.
Okay, so promising, but maybe not its primary indication yet.
Right. And finally, for sarcopenia, that age-related loss of muscle mass and strength, the source reiterates MHT's positive effects. It notes that muscle tissue actually has estrogen receptors, and estrogen therapy can help preserve muscle mass and strength. Again, the benefits seem most pronounced when therapy is started earlier in menopause.
That's a really comprehensive overview of the potential benefits tackling both the day-to-day quality of life issues through symptom relief and also addressing these critical long-term health risks like bone loss, heart disease, and muscle loss. The source also breaks down the different types of hormones and how they're actually delivered, right?
Yes, this is where it gets into the practical details of MHT formulations. The source discusses hormones often falling into categories people hear about, like bioidentical, compounded, and FDA approved. It clarifies that the term bioidentical simply means the hormone molecule has the exact same chemical structure as the hormones your own body naturally produces, or used to produce. Compounded bioidentical hormones, often called CBHT, are custom mixed by a special compounding pharmacy based on a doctor's individual prescription. The source acknowledges this customization can be a valuable option if standard, mass-produced, FDA-approved forms don't quite meet a patient's specific needs or sensitivities, or if certain combinations are desired.
But the source adds a pretty important note of caution about compounded hormones, doesn't it?
It does. A very important caution. The source strongly warns against unsupported claims that compounded hormones are somehow inherently safer or more effective than the rigorously tested, FDA-approved pharmaceutical-grade options. It specifically pushes back hard against claims often made about formulations containing high levels of estriol, like Biest, which is estradiol plus estriol, or Triest, which adds estrone. Claims that these are safer for breast or uterine tissue are not supported by robust clinical trials, the source states, and it emphasizes that estriol, while weaker than estradiol, does still stimulate tissue. The key difference, reiterated, is that FDA-approved forms have undergone extensive clinical trials to prove both their safety and their efficacy at specific doses, and their manufacturing is highly regulated for consistency. Compounded products don't have that same level of large-scale trial data or manufacturing oversight.
Okay, so while compounding offers customization, you should be really skeptical of broad claims about superior safety that aren't backed by solid evidence.
Got it.
What about the main hormones themselves that are used in MHT?
The source primarily focuses on estrogen and progesterone, and also discusses testosterone briefly. Estrogen therapy can be delivered systemically, meaning the hormone enters your bloodstream and travels throughout your body to affect all the tissues with estrogen receptors. This systemic delivery can be achieved through pills, oral estrogen, patches worn on the skin, transdermal, or gels, creams, or sprays applied to the skin, also transdermal. Systemic therapy generally provides the most comprehensive relief from symptoms like hot flashes and offers those long-term protective benefits for bones, heart, etc., but it can also carry a slightly higher potential for side effects compared to local therapy.
And the source makes a distinction even within systemic estrogen, right, between pills and skin delivery.
Yes, this is another point it reiterates clearly. Oral systemic estrogen pills carries a slightly higher risk of developing blood clots, like DVT or PE, potentially increasing blood pressure, and causing less favorable changes in triglycerides compared to non-oral forms like patches, gels, or sprays. This difference is because when you swallow an estrogen pill, it first goes through your liver. This is called the first pass effect. The liver processes it in a way that can activate certain clotting factors and influence lipid production differently. Transdermal forms, patches, gels, sprays, bypass this first pass through the liver because the estrogen is absorbed directly into the bloodstream through the skin. This generally avoids those specific impacts on clotting factors and triglycerides seen with oral estrogen.
Okay, that's a really important distinction for risk assessment. What about local estrogen?
Right. Estrogen can also be delivered locally, primarily for treating those genitourinary symptoms of menopause, GSM. This involves using low-dose estrogen products directly in the vagina, like creams, tablets, vaginal rings, or suppositories. These products deliver estrogen mainly to the vaginal and lower urinary tract tissues where it's needed for GSM symptoms. Very little estrogen from these local products gets absorbed into the rest of the bloodstream. So the source is very clear. Local vaginal estrogen is excellent for treating the symptoms of GSM like dryness, irritation, and pain with sex, but it does not provide the systemic benefits for hot flashes, bone protection, brain health, or cardiovascular protection. You need systemic estrogen for those broader effects.
Got it. Systemic for whole body effects, local specifically for vaginal and urinary symptoms. Now, what about progesterone? You mentioned that's often needed too.
Yes, and this is Absolutely critical. Progestogen, which includes progesterone itself and synthetic versions called progestins, is necessary if you still have your uterus and you are using systemic estrogen therapy. The source reiterates this point emphatically. Why? Because taking estrogen alone when you have a uterus can cause the uterine lining, the endometrium, to thicken too much. This is called endometrial hyperplasia, and it significantly increases the risk of developing endometrial cancer. Adding a progestogen opposes estrogen's effect on the uterine lining and provides crucial protection against hyperplasia and cancer. The source mentions FDA-approved progestogen options like oral pills, micronized progesterone is often preferred as bioidentical, or progestin-containing IUDs like Mirena. It notes, however, that while IUDs provide excellent local protection for the uterus, they release very little progestin systemically, so they wouldn't offer any potential systemic benefits of progesterone itself, like maybe aiding sleep for some women.
Okay, progestogen is essential uterine protection with systemic estrogen. But the source issues a specific warning about one type of progesterone, right?
A very strong warning, yes. It strongly cautions against relying on transdermal compounded progesterone creams for endometrial protection when using systemic estrogen. The source states clearly that research shows progesterone is poorly absorbed through the skin from these creams. The levels reaching the bloodstream and, more importantly, the uterus are often insufficient to reliably protect the endometrium. So, relying solely on these creams while taking systemic estrogen puts you at a significantly increased risk of developing endometrial hyperplasia or even cancer. That is a crucial safety point the source wants every woman and provider to understand. Don't rely on progesterone cream alone for uterine protection.
That is a really, really important safety warning to remember. Okay, lastly, what does the source say about testosterone therapy for women?
It does discuss testosterone use. It's often prescribed off-label for women in the U.S., though approved in some other countries, primarily for treating hypoactive sexual desire disorder, HSDD basically, low libido that's causing distress. Sometimes it's also used off-label to help with persistent fatigue, maybe contribute to bone density, or combat muscle loss, sarcopenia, often in combination with estrogen therapy. However, the source notes that research on testosterone therapy specifically in women is relatively newer compared to estrogen and progestogen. There's still ongoing research and discussion about what constitutes normal or optimal testosterone levels for menopausal women, and less is known about very long-term safety and tolerance compared to MHT. Common delivery methods mentioned are compounded creams applied to the skin, pellets inserted under the skin, or maybe sublingual under the tongue, or buccal in the cheek forms. But importantly, the source issues another strong caution against most oral forms of testosterone, like methyltestosterone, which used to be combined with estrogen in some older products, due to a significant risk of severe liver toxicity. It does mention that oral testosterone undecanoate is one form that has been studied more recently for HSDD and might be an exception regarding liver risk, but generally, non-oral routes are preferred for women.
And it sounds like getting the dose right with testosterone is absolutely critical.
Absolutely critical. The source warns explicitly against using what it calls superphysiologic dosing. That means using doses that push your testosterone levels far above the normal range typically found in healthy young women. This high dosing can lead to unwanted masculinizing side effects like increased facial or body hair, hirsutism, deepening of the voice, which can be permanent, enlargement of the clitoris, clitoromegaly, acne, and sometimes negative mood changes like irritability or aggression. But beyond those cosmetic or mood effects, superphysiologic doses can also have serious metabolic consequences, causing unfavorable changes in cholesterol, increasing bad LDL, decreasing good HDL, potentially damaging the liver, increasing blood clot risk, and even paradoxically increasing visceral fat. The goal, the source reiterates, should always be to use a physiologic dose, a dose aimed at restoring testosterone levels to within the normal healthy range for a premenopausal woman, not exceeding it. And it stresses the vital importance of routine blood level monitoring while using testosterone therapy to ensure the dose is appropriate and safe.
Okay, so navigating MHT really involves understanding all these pieces. The different hormones, estrogen, progestogen, maybe testosterone, how they're delivered, oral versus transdermal versus local. The critical nuances like needing progestogen with a uterus, avoiding certain formulations like progesterone cream for protection, and being extremely careful with testosterone dosing. The source also makes it clear that MHT dosing isn't one size fits all, right?
It absolutely reiterates that point. There is no single correct starting dose or formulation that works for everyone. Finding what's optimal for you is often a process of trial and adjustment. It requires working closely with your doctor, monitoring your symptom response, checking for side effects, and being patient as you maybe try different doses or delivery methods to find the best fit. It's personalized medicine.
Are there specific situations or medical conditions where MHT is generally considered not appropriate or contraindicated?
Yes, the source lists the key, widely accepted contraindications. These include having undiagnosed vaginal bleeding, needs investigation first, a history of or active arterial blood clots, like a recent heart attack or stroke, or a history of or active venous blood clots, like a deep vein thrombosis or pulmonary embolism. A history of estrogen-sensitive cancers like breast cancer is also a complex area requiring specialist consultation, though not always an absolute contraindication anymore, especially for local therapy.
Okay. And there's also that common confusion or myth about MHT and migraines that the source specifically tries to clear up.
Yes, it explicitly tackles this because it's a frequent barrier for women. It states clearly that having a history of migraines does not automatically mean MHT is unsafe or off the table. That's a persistent false claim. The source explains the nuance. Current evidence shows no increased risk of stroke associated with standard MHT doses in women who experience migraines without aura. Now, for women who do experience migraines with aura, those neurological symptoms like visual changes before the headache, the conversation is definitely more complex and requires a very careful discussion with a knowledgeable provider, weighing individual risks and benefits. However, the source points out a crucial difference. The doses of estrogen used in MHT are much, much lower than those found in combined hormonal contraceptives, like birth control pills. The contraindication or strong caution often seen regarding combined contraceptives in women with migraine with aura has not been identified for the lower doses used in MHT for treating menopausal symptoms or headaches. It's a different risk profile.
That's a really important clarification for the many women who experience migraines and might have been told MHT is absolutely forbidden. What about more common, maybe less serious side effects people might encounter when starting MHT?
The source mentions the most typical ones are things like unscheduled uterine bleeding or spotting, especially in the first few months, and breast tenderness. The unscheduled bleeding is noted as being quite common, maybe affecting around 40% of patients initially. It's often expected, kind of like the uterine tissue waking up in response to estrogen after a period of low levels. Usually this settles down within 3 to 6 months as the body adjusts. However, the source is also clear. Persistent or heavy bleeding that continues beyond that initial adjustment period or starts unexpectedly later on absolutely warrants further investigation, like a pelvic ultrasound or maybe an endometrial biopsy, to rule out any other underlying causes besides the MHT itself. Less common side effects might include things like nausea, bloating, or fluid retention. The source suggests these can often be managed by adjusting the dose, maybe switching the type or delivery method of the hormone, for example from oral to transdermal, or sometimes using other supportive measures, always in consultation with your doctor.
Okay, that gives a really thorough picture of MHT as presented in the source, covering the updated view on benefits versus risks, the different formulations, the crucial safety points, and managing expectations around dosing and side effects. It really highlights that while it can be complex, MHT is presented as a powerful and often safe option for many women when it's prescribed and managed correctly by an informed provider. And that leads us perfectly into the next really crucial section, taking action. How can you, the listener, actually empower yourself on this menopause journey?
Yes, this part really circles back to that core message from the source. With education comes power. It's all about translating the knowledge we've been discussing from this deep dive into practical, actionable steps you can take. And the very first step, which you kind of touched on when discussing the systemic issues in medicine, is finding the right healthcare provider for you.
Right. Because, as the source points out, even if you love your long-term family doctor or your regular OBGYN, given those gaps in standard medical training we talked about, they might not actually be the most up-to-date or comprehensive resource specifically for menopause care, even if they're fantastic doctors in other ways.
The source explicitly reiterates this challenge. Remember, the author, Dr. Haver, admitted her own standard OBGYN training was insufficient for years regarding menopause. So the source encourages you. It's perfectly okay, and often even advisable, to seek out a new provider who has specialized knowledge, specific training, or just a particular interest and focus on menopause care.
And the source actually provides some resources to help you find such a provider.
It does. It recommends checking out the website thepauselife.com, which Dr. Haver founded. It features a database of recommended physicians, apparently compiled from patient submissions based on positive experiences. It also suggests using the Find a Practitioner tool on the Menopause Society's official website, which is menopause.org, that allows you to search for certified menopause practitioners in your area. And the source adds a really practical tip. Call the offices of potential providers beforehand. Ask specifically if the doctor discusses menopause in detail and is open to talking about the full range of therapeutic options, including MHT. Don't assume every OBGYN is a menopause expert. And while an in-person visit is often ideal for a full physical assessment, the source also emphasizes that getting good virtual care from a provider who really listens and is knowledgeable about menopause is significantly better than getting no care, or worse, getting dismissed during an in-person visit with someone who isn't up to date.
Okay, so step one, actively seek out a knowledgeable and open-minded provider. What's the next key action step?
Preparing thoroughly for your appointment. This is highlighted as critically important for making the most of that visit. You need to go in ready to discuss all the potential therapeutic options that might be relevant for you, including MHT, and have some understanding of which ones you might be interested in exploring. And here's that surprising point again. The source suggests you might actually need to be prepared to bring updated scientific information with you to your doctor's appointment.
Bring the doctor information. That still feels a bit like flipping the usual script, doesn't it?
It does, but the source explains why this might be necessary. Because of those gaps in mandatory up-to-date menopause training for board recertification, it's possible your doctor simply hasn't received or reviewed the latest scientific updates. For example, they might not be fully aware of the nuances in the 2022 Menopause Society position statement that outlines the favorable benefit-risk profile of MHT for many women under 60. The website, thepauselife.com, apparently offers specific articles based on current evidence that you can print out and bring to your appointment to facilitate the discussion. It's framed as partnering with your doctor to ensure the conversation is grounded in the most current understanding.
That's truly empowering advice.
Okay.
Don't be afraid to proactively share the science if you feel it's needed. What else helps make the appointment productive?
Preparing specific questions you want to ask is always helpful, of course. And crucially, the source strongly recommends tracking your symptoms. It stresses the immense value of keeping a detailed symptom diary for a few weeks leading up to your appointment. Or, using a more formal symptom scoring tool, the source mentions there's one in its appendix, though the specific tool isn't the point, just the act of tracking. Why is this so valuable? It gives you objective data to share. The source mentions that a symptom score above a certain threshold, say 15 or higher on a standardized scale, strongly suggests that estrogen deficiency is likely a significant contributor to how you're feeling, and it really warrants a serious discussion about therapy options. It notes many women seeking help have scores much higher, maybe in the 20s, 30s, 40s, or even 50s, indicating a major impact on quality of life. And you should expect these scores to decrease substantially with effective treatment.
Right. Tracking symptoms moves it from vague complaints to concrete data you can discuss. The force also recommends asking for some specific blood tests that go beyond a standard annual checkup.
Yes, these specific tests are highlighted because they provide deeper insights into some of the health risks that are particularly relevant during the menopause transition. For cholesterol, for instance, the source recommends getting the standard panel: total cholesterol, LDL bad, HDL good, and triglycerides. But it strongly emphasizes also asking for two additional markers: ApoB, apoprotein B, and LPA, lipoprotein. It reiterates that ApoB and LPA are considered by many experts to be more specific and powerful predictors of cardiovascular disease risk than the standard lipid panel alone. Getting these checked is especially important given the known increase in CVD risk that accompanies menopause.
Okay, that's a really key takeaway push for ApoB and LPA, beyond the standard cholesterol check. What other specific tests does the source suggest discussing with your doctor?
A comprehensive thyroid panel. The source stresses that just checking the TSH, thyroid-stimulating hormone, which is often the only thing screened, is frequently insufficient. You should ask for TSH, but also free T4, free T3, reverse T3, and the thyroid antibodies, specifically anti-TPO and anti-thyroglobulin antibodies. The source reiterates why this full panel is so important. Undiagnosed or subclinical thyroid disorders are actually quite common, especially in women around midlife, and their symptoms can perfectly mimic many common menopause complaints. We're talking fatigue, unexplained weight changes, mood swings, depression, anxiety, forgetfulness, hair loss, constipation. The overlap is huge. Ruling out or properly diagnosing a thyroid issue is absolutely crucial before attributing everything solely to menopause.
Wow. Okay. So many symptoms we assume are menopause could potentially be thyroid related, and you really need that full panel to differentiate. Makes sense.
Exactly. The source also recommends an anemia panel. This should include checking your iron levels, ferritin, which reflects your body's iron stores, folate, vitamin B9, and vitamin B12. It reiterates why. Chronic persistent fatigue is incredibly common in perimenopausal and postmenopausal women. The source says it affects over 70%. And anemia, low red blood cells, or even just iron deficiency without full-blown anemia, low ferritin, is a major, often overlooked contributor to that fatigue. B12 deficiency can also cause fatigue and neurological symptoms and can be related to dietary intake or absorption issues that sometimes worsen with age.
Given how debilitating fatigue can be, checking those nutrient levels seems fundamental.
It really does. Finally, the source recommends checking for markers of chronic inflammation, specifically asking for high-sensitivity C-reactive protein, hsCRP, and erythrocyte sedimentation rate, ESR. It reiterates why. As we discussed, the decline in estrogen during menopause leads to a loss of its natural anti-inflammatory effects. This can allow a state of low-grade chronic inflammation to develop throughout the body. This chronic inflammation is believed to be a key underlying factor contributing to many of the long-term health risks associated with menopause, like joint pain, increased cardiovascular risk, insulin resistance, and possibly even neuroinflammation linked to cognitive decline. Tracking these markers like hsCRP and ESR can help assess your baseline level systemic inflammation and potentially see how interventions, including lifestyle changes and maybe MHT, are impacting it over time.
Okay, so these specific tests, the advanced lipids, the full thyroid panel, the anemia nutrient check, and the inflammation markers, they all work together to provide a much more detailed, personalized picture of your underlying health status and risk profile, going way beyond just confirming whether or not you're in menopause. Now, in addition to all these medical considerations, finding the right doctor, preparing for visits, getting the right tests, discussing MHT, the source heavily emphasizes the absolutely critical role of lifestyle strategies.
Yes, these are presented as the absolute core foundation of care. They are essential whether or not you choose to use MHT or even if you're not a candidate for it. Anti-inflammatory nutrition is presented as a key pillar.
What does that kind of anti-inflammatory nutrition look like according to the source?
The source reiterates the core principles. It's about focusing on whole, unprocessed foods. Lots of healthy fats, think olive oil, avocados, nuts, seeds. Plenty of lean protein sources, fish, poultry, legumes, tofu. Abundant antioxidant-rich fruits and vegetables of all colors. High fiber foods like whole grains, beans, lentils. And, conversely, significantly limiting processed foods, refined carbohydrates, sugary drinks, excessive saturated fat, and alcohol. The source explains why this way of eating is so crucial specifically during menopause. It helps counteract the loss of estrogen's natural anti-inflammatory effect. It supports healthy weight management, particularly helping to combat that tendency to gain visceral fat around the middle. It helps maintain bone density, and it directly reduces the risk of developing chronic diseases like heart disease, type 2 diabetes, and potentially even certain cancers. It specifically highlights the benefits of choosing low glycemic index foods, foods that don't spike your blood sugar for better blood sugar control, improved metabolism, and even more stable mood.
Okay, makes sense. What about specific macronutrients like protein and fiber?
Protein intake is strongly emphasized. The source recommends aiming for a higher intake than may be previously thought typical, suggesting a goal of 1.2 to 1.6 grams of protein per kilogram of your ideal body weight per day. It explains why this higher protein intake is so important. Protein is absolutely vital for maintaining and even building muscle mass, which directly combats sarcopenia, age-related muscle loss. Good muscle mass supports a healthy metabolism, helps improve insulin sensitivity, fighting insulin resistance, and keeps you strong and functional. Fiber intake is also stressed with a goal of 25 grams or more per day. It explains why. Fiber is crucial for gut health. It feeds the beneficial bacteria in your gut microbiome, which plays a huge role in inflammation, metabolism, and even mood. Fiber also helps with satiety, blood sugar control, and can aid in reducing visceral fat accumulation. The source also briefly mentions some specific supplements that may have beneficial effects related to inflammation or metabolism based on some studies. Things like omega-3 fatty acids from fish oil or algae, fiber supplements if dietary intake is low, Certain probiotic strains like lactobacillus and bifidobacterium, maybe borage oil for GLA and other fatty acid, and antioxidants like vitamin C and E. However, it also includes a strong caution against believing exaggerated claims about miracle cures from high-dose supplements. The foundation should always be the whole food diet.
Right. Nutrition is clearly presented as a fundamental pillar for managing menopause health. What about exercise?
Exercise is presented as equally crucial. The source calls the combination of cardiovascular aerobic exercise, A&D resistance strength training, an unbeatable combination for health during and after menopause. It reiterates why you really need both. Cardio exercise is key for burning calories, improving heart health, and specifically helping to reduce that dangerous visceral fat stored around your organs. Resistance training, on the other hand, is presented as absolutely essential for building and maintaining lean muscle mass. This directly counteracts sarcopenia. More muscle boosts your metabolism. Muscle burns more calories at rest than fat does. Strength training is also critical for improving bone strength and density, which is vital for preventing osteoporosis and fractures. Plus, it improves balance and stability, reducing the risk of falls. The source recommends aiming for resistance training sessions that challenge your muscles 2 to 3 times per week for significant benefits.
Okay, so exercise isn't just for weight control. It directly tackles several of the key long-term risks, like muscle loss, bone loss, and metabolic issues. What about managing stress and prioritizing sleep? Those often take a hit during menopause, too.
Absolutely. Stress reduction is highlighted as really vital. The source reiterates why. Chronic stress leads to constantly elevated levels of the stress hormone cortisol. High cortisol increases inflammation throughout the body and specifically promotes the storage of fat deep in the abdomen, visceral fat, which just compounds all the other metabolic risks. So finding effective ways to manage stress not only benefits your mental well-being, but can also lessen the severity of many physical menopause symptoms and reduce those harmful effects of cortisol. Practices mentioned in the source include things like mindfulness, meditation, deep breathing exercises, journaling, spending time in nature, yoga, tai chi, and sometimes seeking professional support through counseling or cognitive behavioral therapy, CBT.
Makes sense. And sleep. Menopause is notorious for wrecking sleep.
It really is. The source calls menopause a notorious sleep disruptor, often due to night sweats interrupting sleep, an increased risk of developing obstructive sleep apnea, OSA, after menopause, and sometimes heightened anxiety or racing thoughts making it hard to fall asleep or stay asleep. It reiterates why getting consistently poor sleep is so dangerous for your health. It messes with hormones like cortisol and ghrelin, hunger hormone. It's strongly linked to a higher risk of developing OSA, chronic insomnia, depression, anxiety, high blood pressure, type 2 diabetes, heart attack, and stroke. Lack of sleep is not trivial. Therefore, focusing intensely on good sleep hygiene is essential. That means things like maintaining a consistent sleep-wake schedule even on weekends, optimizing your bedroom environment, cool, dark, quiet, avoiding caffeine and alcohol close to bedtime, limiting screen time before bed, and avoiding heavy meals late at night. For persistent sleep problems, the source suggests that seeking help from a sleep specialist or exploring evidence-based therapies like CBT for insomnia, CBTI, or stimulus control therapy might be necessary.
Wow. Those are all really significant, actionable lifestyle areas. Nutrition, exercise, stress, sleep that you can proactively work on to improve your health during and after menopause. And finally, the source mentions one more element, the importance of community connection.
Yes, it acknowledges that navigating menopause can sometimes feel really isolating. Maybe your friends aren't experiencing the same things yet, or maybe you just feel like no one understands what you're going through. So connecting with other women who get it, who are going through or have gone through similar experiences is highlighted as incredibly valuable. This might happen through social media groups, online forums, or local support groups. The source mentions examples like online communities associated with thepauselife.com. These communities can provide a powerful sense of validation. You're not crazy, a place to share information and practical strategies that have worked for others, and crucial emotional support and friendship during what can be a challenging time.
Okay, so that taking action section really brings it all together. Finding the right medical partner, going prepared with your own knowledge and symptom tracking, utilizing specific tests to really understand your body's status, building that super strong foundation with targeted nutrition and exercise and stress management and sleep, exploring all the appropriate medical interventions like MHT if needed and desired, and finding community support.
Exactly. It's all about shifting from feeling perhaps powerless or dismissed by the changes happening to feeling informed, prepared, and proactive, becoming an active partner with your healthcare team in managing your health through this transition and beyond.
And that leads us perfectly into our final section, which is all about connecting these dots back to that bigger picture. Proactively mitigating those significant long-term health risks that the source emphasizes again and again are so crucial to address.
Precisely. The source consistently brings the focus back here. Yes, managing symptoms like hot flashes or brain fog is important for your quality of life right now, but addressing the underlying hormonal shift and its cascading effects on your various body systems is absolutely fundamental for your future health, your vitality, and your longevity. The source reiterates the importance of prioritizing the prevention and management of these key conditions linked to menopause: osteoporosis, bone loss, coronary artery disease, CAD, insulin resistance leading to prediabetes and type 2 diabetes, neuroinflammation linked to cognitive decline, and potentially Alzheimer's risk, the accumulation of that dangerous visceral fat, and sarcopenia, muscle loss.
Okay, let's quickly synthesize that one more time. How does the source connect these key risks back to menopause, and how do the actions we've discussed help address them?
Okay, let's recap. For osteoporosis, the source reiterates that the sharp decline in estrogen directly accelerates bone loss, significantly increasing the risk of fractures later in life, including those devastating hip fractures which carry high rates of disability and mortality. MHT is highlighted as a primary medical strategy for preventing bone loss and reducing fracture risk. Alongside MHT, essential lifestyle factors are resistance training, which directly stimulates bone building, ensuring adequate calcium and vitamin D intake, and potentially considering supplements like creatine, which may help muscle function and indirectly bone, and specific types of collagen peptides. The source mentions Fortibone as one study type for bone. For cardiovascular disease, the source reiterates that the risk increases significantly during the menopausal transition itself. This is driven by unfavorable changes in cholesterol profiles. LDL often rises, HDL may fall, triglycerides often increase systemic inflammation, and that tendency to gain fat around the middle, visceral fat. It reinforces the protective role estrogen plays on blood vessels and metabolism, underscoring the importance of the timing hypothesis for maximizing MHT's cardiovascular benefits if started early. Key actions reiterated include getting those advanced lipid tests, APO, LPA, adopting that anti-inflammatory, heart-healthy diet, engaging in regular cardio exercise, and absolutely eliminating smoking.
Got it. And for metabolic health, encompassing things like insulin resistance, type 2 diabetes risk, and non-alcoholic fatty liver disease, NAFLD.
The source reiterates that women become more susceptible to these issues after menopause. This is linked again to the loss of estrogen's beneficial metabolic effects, combined with factors like increased inflammation, visceral fat accumulation, and loss of metabolically active muscle mass. It mentions the potential, though still needing more definitive research for this specific indication, for MHT to offer some protective benefit here, especially transdermal estrogen for NAFL. But crucially, it emphasizes the immense power of lifestyle interventions. Sticking to that low glycemic index, high fiber, adequate protein diet, getting regular exercise, especially resistance training to build muscle and improve insulin sensitivity, managing stress effectively, prioritizing good sleep, and potentially considering specific supplements known to impact metabolic health, like berberine, omega-3s, or certain probiotics, always under guidance.
Okay, what about neurocognitive decline, including the risk for conditions like Alzheimer's disease?
The source links the increased risk observed in women partly to the loss of estrogen's protective effects in the brain and potentially increased neuroinflammation after menopause. It reiterates the potential cognitive benefits shown in some research for MHT, particularly when it's initiated earlier in the menopause transition and used for a sustained period. Lifestyle factors like exercise, diet, and managing cardiovascular risk are also crucial for brain health.
And sarcopenia, that loss of muscle mass and function.
The source notes this is accelerated not just by chronological aging, but specifically by the conditions common in menopause: chronic inflammation, developing insulin resistance, reduced physical activity perhaps, and the direct loss of estrogen's anabolic muscle-building support effects. It reiterates the significant impact this muscle loss has on strength, mobility, overall metabolism, and increasing the risk of falls and frailty. MHT is discussed as being potentially beneficial for preserving muscle mass, but the absolutely critical lifestyle components reiterated are consuming sufficient high-quality protein daily and engaging consistently in progressive resistance training to stimulate muscle growth.
And finally, wrapping it all together, is that issue of chronic inflammation, which seems to be a thread running through so many of these risks.
Yes, the source reiterates that menopause itself seems to introduce or worsen a state of low-grade chronic systemic inflammation, primarily due to the loss of estrogen's potent anti-inflammatory signaling. This underlying inflammatory state is believed to contribute significantly to the development or worsening of many conditions, from joint pain and potentially asthma or autoimmune issues, right through to cardiovascular disease, insulin resistance, NAFLD, sarcopenia, and neurodegeneration. Therefore, the source constantly reinforces that adopting a comprehensive anti-inflammatory lifestyle, focusing on that anti-inflammatory nutrition pattern, regular exercise, effective stress reduction techniques, and optimizing sleep are fundamental strategies to actively counter this chronic inflammation.
Okay, so really understanding these connections between the symptoms you feel, the underlying hormonal changes, and these potential future health risks is the key. And knowing that there are proactive, evidence-based steps, both medical and lifestyle, that you can take to address both current issues and future risks.
Absolutely. That is the core message of empowerment the source conveys. Armed with this comprehensive understanding, gleaned from sources like Dr. Haver's work that we've explored today, you are significantly better equipped. Better equipped to have informed, productive, collaborative conversations with your doctor. Better equipped to make deliberate, personalized choices about the mix of interventions, whether that includes hormonal therapies like MHT, non-hormonal options, or focuses primarily on targeted lifestyle strategies that are best suited to your individual symptoms, your personal risk profile, and your health goals. The ultimate aim, as presented here, is both finding relief and improving your quality of life today and actively protecting your health and vitality for all the decades to come after menopause.
That framing is just so different, isn't it?
Yeah.
Moving from perhaps passively experiencing these changes to actively, intentionally shaping your health future. It feels incredibly powerful.
It really is. It encourages you, the listener, to view this significant life stage not as some inevitable decline you just have to endure, but actually as an opportunity. An opportunity now equipped with knowledge and agency to really invest in your well-being in significant, targeted ways, leveraging all the wisdom and experience you've gained throughout your life so far.
And that actually brings us perfectly to a final provocative thought for you to consider as we wrap up this deep dive today. The source, and just reality, highlights that with modern life expectancies, many women listening will likely live 30, 40, maybe even more years after they officially reach menopause. That's a huge chunk of life. You now have, hopefully, much deeper insights from our discussion today into the biological shifts happening, the potential risks that can emerge, but also, crucially, the knowledge about the wide range of strategies available to manage symptoms and actively mitigate those long-term risks. So the question to ponder is, what does it really mean for you personally, knowing all this now, to intentionally invest in your health, your vitality, your function, and your overall well-being for this potentially very long and significant second half or maybe even third act of your life?
Yeah, it really becomes a question about agency, about priorities. How will you use this understanding, this knowledge we've unpacked today, to consciously shape the quality and the health span of those many postmenopausal years ahead?
A truly meaningful question to leave you with. Thank you so much for joining us for this deep dive into navigating your path through menopause, drawing these crucial insights from the work of Dr. Mary Claire Haver in the New Menopause. We sincerely hope this conversation has provided clarity, validation, and a strong sense of empowerment.
Thank you. And once again, please, please remember, all the information shared here is for educational purposes only. It is absolutely not a substitute for personalized medical advice from your own qualified healthcare provider. Always consult your doctor.
Absolutely. Until next time, keep diving deep into the topics that matter most to you.